Hi everyone. Today I'll be dealing with the topic pit and fissure sealant. Pit and fissure sealant is important in terms of the preventive aspect where we can prevent the development of the dental caries, especially when coming to the young permanent molars as well as the primary molars. So pit and fissures always the other areas susceptible for the dental caries because of the food lodgement. So early detection of dental caries has to be done, and then we have to go for the sealant for a preventive aspect of development of the dental caries, because the pit and fissures, these are the areas where the toothbrush bristles are inaccessible to remove the food lodgement. So what is a pit? Pit can be defined as a small pinpoint depression located at the junction of the developmental grooves or at terminals of these grooves, as by Ash in 1993. And fissure, it's a deep cleft between the adjoining cusp. You can see here, these are the fissures and these are the pits. So Nango in 1960 has classified the pit and fissures into various types depending upon the structure, that is V type, U type, I type, IK, and inverted Y type. So among these pit and fissures, V and U are considered as a self-cleansing pit and fissures, whereas I, IK, and inverted Y are susceptible to caries. Coming to the histopathology, when we take the pit and fissures, there is a neck of fissure, body of fissure. So these are the areas where your brush bristles won't be accessible, and there is a chance of development of the dental caries. So the main intention of the sealant is flowing the material into these deep pit and fissures so that we can prevent the food lodgement, thereby prevention of development of dental caries. So how do you judge which case has to go for a pit and fissure? So one is softness at the base of the area, that opacity or loss of normal translucency adjacent to the pit and fissures as seen in this picture, or softened enamel adjacent to the pit or fissure that can be straight away with the explorer. Now coming to the definition of pit and fissure sealants. Pit and fissure sealants can be defined as whereby pits and fissures that occur principally on the occlusal surface of the molars and premolar teeth are occluded by the application of fluid materials, which are then polymerized. There are certain requisites for an efficient pit and fissure sealant. One is viscosity. The material should be adequate. It should be adequate viscosity so that it will be able to flow into all the susceptible pit and fissures. And it should have an adequate working time, and it should rapidly cure, and it should have a good and prolonged adhesion to the enamel, low absorption and solubility in the oral fluids, and it should be resistant to the occlusal wave. The minimum irritation to the tissues, that is, it should be biocompatible, and it should also provide a karyostatic action, thereby preventing the development of the dental caries. Simonson has classified the patients into group 1, group 2, group 3, and normally the pit and fissure sealants are mainly intended for the group 2 patients, where the patients with moderate risk of developing dental caries. Now, what are the indications of pit and fissure sealants? So they are mainly indicated in newly erupted teeth with patient judged to be at moderate risk, as I've told, it's a Simonson's class 2 category. Then complete recession of the pericoronal operculum, because there should be a proper isolation when applying the pit and fissure sealants. Then open or sticky grooves and fissures. Then as I've told, there should be the isolation of tooth should be possible to control the moisture. Another indication is stained pit and fissures with minimum decalcification or opacification and no softness at the base of the fissures. And if the patient's second primary molar is carious, it is better to seal the permanent first molars, where the patient parent has to be informed earlier. And if one first permanent molar is carious, it is always better to seal the other first permanent molars too. If all the first permanent molars are carious, it's better we seal the second permanent molar soon after the eruption. And it's also indicated in children with special healthcare needs, where they lack the manual dexterity for cleaning their tooth. So especially in medically compromised patients or mentally or physically challenged patients. And one more indication is that the tooth in question should have erupted less than 4 years ago. Contraindications: if the tooth has remained caries-free for 4 years or longer after eruption, there is no need of going for pit and fissure sealant. the tooth which cannot be isolated also, where we can't maintain a proper moisture control, it's better not to apply the sealant. Then caries on the proximal surface of the tooth. Caries-free patients judged at no risk to decay, and patients with rampant caries at a high risk. These comes as the Simonson's group 1 and group 3. Then well-coalesced and self-cleansable pit and fissures, as I have told, that is the type that is V and U type. Now, there are age ranges for the sealant applications. That is 3 to 4 years. We mainly aim for preventing the development of dental caries in primary molars. 6 to 7, it's for the permanent first molars. 11 to 13 is for the premolars and the second permanent molars. Now, selection criteria is based on the clinical judgment. As I've told, age matters, that oral hygiene status of the patient, then familial or hereditary tendency to develop dental caries, then fluoride environment and history, then dietary habits of the patient, then tooth type and morphology, as I've told, according to the NANGOS classification. Now, what are the predictive factors in staying fissures? Is findings on the other first permanent molars, then history of previous caries, and if the patient is a high caries risk based on their dietary considerations. Now, coming to the classification of pit and fissure sealant, Mitchell and Gordon in 1990, he has classified according to the method of polymerization to 4 generations. The first generation being the ultraviolet, second generation being the self-cure, and third generation being the visible light, and fourth generation fluoride releasing. And we can also classify according to filler particles incorporated as filled and unfilled, which filled pit and fissure sealants, they will be more resistant to the occlusion, masticatory forces. Then according to the coloring pigments, it can be classified into clear, tinted, and colored. Colored being more advantageous because during the follow-up visits, we can always check whether the pit and fissure sealants are lost or not. Then according to the resin system, Bismarck, coming back, procedure wise, so isolation is a must based on the cotton rolls, as well as we can go for the rubber dam application. Now, etchings, the goal of etching is to create micro porosities where the sealants, mainly we know that the pit and fissure sealants, they bond by the micromechanical bonding. So the etchant is applied. Acid etching is done. It varies depending upon the tooth. That is 30 seconds for the primary tooth and 20 seconds for the permanent tooth. And then wash off the etchant. That is 37% phosphoric acid. Okay. Then after that, you dry the cavity, dry the tooth, sorry. Now, coming to the scientific basis, as I've told, its main intention is to create resin tags. So we'll be applying the etchant and creating microporosities on the enamel surface so that when you apply the sealant, these resins will form resin tags, thereby leading to micromechanical retention. So as I've told the procedure, we have to first do the oral prophylaxis, then go for the isolate with the rubber dam, then apply the etchant, then followed by washing and drying, and then application of the sealant. After applying sealant, it's better we run a probe through the sealant so as to remove the air bubbles, so as to prevent the development of the voids. And once you feel that all air bubbles are removed, you have to cure the sealant. Then check for the after that, check for the high points and then give a proper instructions to the patients. Now, coming to the comparison between sealant and amalgam, it's one of the method of minimal invasive dentistry. That is, there is minimal tooth loss. There is no need of cutting. There is no need of enamel cutting. So it's a minimal tooth loss. Then reapplication can be done on loss of sealant materials, unlike your amalgam, where we again have to modify the cavity. Then time taken is less, but it is highly technique sensitive because utmost moisture control has to be done, and it is cost effective too. So newer materials for the recent advancements in the sealant is one is type 4 GIC can be used as a sealant, fluoride releasing, then biological pit and fissures. Colored pit and fissure, I told you, it will help in more advantages during the recall visits we can see for the retention. Clear pit and fissure sealants, fluorosing pit and fissure sealants, then wet bond sealant, that is especially embraced, which where adequate moisture control is not required. Then pit and fissure sealant with amorphous calcium phosphate, where there is additional remineralizing capacity also. Now, failures in sealant placement, what are the failures? One is I told you technique sensitive. If you don't isolate properly, and if there is a moisture contamination, retention becomes a major problem. One is moisture contamination, another is if you don't do inadequate etching, then incorporation of air bubbles which lead to voids can also be a failure. Then incomplete removal of debris prior to the etching. So these are the one of the causes. These are the one of causes for the failure of sealant application. Another is ability of operator to apply under optimal clinical conditions. And most frequently, we can see that there is loss from the lingual surface of the maxillary molars and buccal surface of the mandibular molars being the functional cusp of the tooth. Then retention rates, it's less in primary teeth when compared